ahead and get started. Welcome everyone to our presentation about high value care at end of life. We're excited to share this project and the results that we've come up with thus far, and are happy that you're able to join us. Sorry. I'm Kari Degerness. I'm the Director of Healthcare Programs here, and I'm joined by Megha Jha, who's our lead analyst on this project, and we'll hear from her a little bit later. Just a couple housekeeping items. Please do send in questions in the chat box. We'll address those at the end. And if there's a question specifically about any of the data points, we can do that at the time of the slide as well, but please do chat those questions in. This session will be recorded and we will be sharing it out and having it posted on our website. So if you're missing a couple facts or things like that during the presentation, it will be there. You can rewatch it and also share it with others. We will have a couple poll questions here, so polls will pop up and we'll make this a little bit more interactive as well. So I wanted to talk a little bit about CIVHC for those who aren't familiar. Our mission is to strive to empower individuals, communities, and organizations through collaborative supportive services and healthcare information to advance the triple aim, which is better health, better care, and lower cost. We are a nonprofit and we are an independent organization and remain objective. And so we hope to just inform through this information. We have a couple different focus areas here at CIVHC. One of the ones that you might most be familiar with is some of our public data sources. We are legislatively mandated to put together these reports that are available on our website. We have grown substantially in the content and complexity of those reports, and so I encourage you to check out our website and look at some of that information, as it can be very applicable to you as an individual healthcare consumer or as a leader in the healthcare space. We also do offer custom data sets if you have a specific question that you want to have answered. We do try and improve data literacy. We understand that reports and things like that can be a little bit hard to read, and we hope that we can enable everyone to get that information from the reports that we do produce. We also do frequent Civic Connect events and try and reach out to the community and inform on our work and different topics within healthcare. And then the programs and convening is what I oversee. We work to be a nonpartisan, non-biased individual group that can bring people together to talk about any issues that are plaguing the healthcare space. Historically, we've focused in on transitions of care, palliative care, and cost of healthcare. And so the work that we've been doing since our inception in the palliative care and the health transition space is very reflective of the work that we'll be talking about today. So we serve a bunch of different individuals and from independent individuals using the data to researchers, nonprofits, and things like that. We hope to just really empower and serve and educate all of our partners. So we'll launch our first poll question. We do want to know a little bit about who's joining us today. So we'll get this poll going, and just please select the category that's best describing you. So whether you are a clinician on the administrative space, if you're a data analytics guru community, or if you're not listed in one of those categories, please do vote. And we'll just have it open for a minute or so. Spencer, are we getting some good answers?
Getting good answers, just about filled.
Okay. Wonderful. All right. And do we have the results? Wonderful. Okay, so we have a pretty even breakout between clinicians, administrative, and the data folks. And I'm very excited that we've got some community partners as well. So wonderful. Thank you for taking the time to do that. All right, I do want to talk a little bit about what's in the all-payer claims database that Civic administers on behalf of the state of Colorado that help to inform the work that's happening with this project. And so we collect payer information from Medicaid, Medicare Advantage, Medicare fee-for-service, and commercial plans that you may have as an individual. All of that information equates to about 5 million lives that are within that database that we can run analytics on. And we have about 70% of the covered lives in Colorado, which makes it a pretty robust set of information that we can use to really find some good facts and information about this population. There are a few things that are not included that we do want to highlight. We don't have federal programs such as the VA, TRICARE, Indian Health Services. So that those pieces are absent from the all-payer claims database. But again, we have most of it. We have ERISA-based plans that voluntarily enroll, but we don't have the majority of them. And of course, we don't get any of that self-pay. So if you pay just cash for services, we are not able to get that information because it does not come through on a claim. A little bit about the project background. I did mention that we have been in the palliative care space and transitions of care since 2009. That work has really brought together a robust group of individuals trying to address those areas. And so with those conversations and bringing people together and talking about this, we really wanted to create this project that can help to inform the work that's happening in those convening spaces. So it really brings together the program's work in which I see, and then the data, and making it actionable to really improve some of the efforts that we have. It is to really hopefully inform the work around serious illness. Palliative care is a big item that we want to be able to help inform and improve use and understanding of, as well as advanced care planning. And I'll touch on a little bit more about what those are in just a minute. This data is also hopefully going to be helping to identify the trajectory of care if you're diagnosed with some disease such as COPD. What does that trajectory of care look like? This information will hopefully be able to help plan that out so you can account for what services you need. And if you don't have those in your current area, potentially looking at those other areas where you could get those cares and services as you need them, and going through the care plan. So the big points of this project are to describe the cost, utilization, and quality of those at end of life. This is a very unique analysis in the fact that it doesn't just inform on the Medicare data. With having all payers, commercial, Medicaid, Medicare Advantage, Medicare fee-for-service, Medicaid, all of those payers have very different ways of providing services. And it isn't something that is done in the current state right now. And so this is something very unique, and we can see the variances and start to address those variances and ensuring that everyone, regardless of payer, has quality of service, quality of care and services at the end of life. We do want to try and identify and understand the use of advanced care planning codes that were implemented in 2016, and also understanding palliative care services as much as we can. Obviously, palliative care is not readily reimbursable, and so those services on claims are very minimal, but we do want to see what we can do with this information to help inform that work. We are doing multiple iterations of this project. So once we're finished with this one and all the data that we're sharing with you today, we're going to be working on the next iteration and being able to provide additional information in a year or so, again, on this project, just a little bit more in depth. So I had talked about the cost trajectory of diagnosis, but we also do want to create a replicatable methodology that can be applied in other states with all payer claims database. So for those that are those data gurus here, we really want to make sure that this information is actionable and it can be produced so we can do comparisons across states. So those definitions, so palliative care is a very unique service that isn't often known very well. It is not hospice care. It is a interdisciplinary team, usually made up of a nursing, physician, social worker, chaplain, and maybe some other supportive services. And it's for those individuals that have really serious illness, such as cancer or, chronic pain and things like that, that need those connected services in multiple facets of care to help support them and get them through that period of time. So it's not just for those at the end of life, it is for those that are going through that serious illness at that time. Palliative care does have a specific definition in the Colorado legislature and the laws that are written. We were able to pass that as part of this group's work many years ago. And so it does include that interdisciplinary team, really focusing on quality of life, supporting the patient, supporting the family, and helping them through that difficult time. Advanced care planning is a process in which you will identify medical wishes should you not be able to make those decisions. It's a specific set of conversations. This is one of our most active work groups right now. We really work to try and improve that understanding. It should be a collaborative discussion between you and your health provider, you and your family, to identify what those needs are. Do you really want CPR? Do you want artificial nutrition? If you become unable to make those decisions yourself and are in a situation in which you need to have those. So it's really critical that everyone over 18 have these conversations, identify someone who you trust, who understands your needs and wishes, and wanting to make sure that you get those wishes granted if you are not able to make those decisions yourself. Throughout the COVID pandemic, this has been brought to the forefront as many families were put in this very difficult situation, in that crisis. And while you're in that crisis situation, making those decisions is really not ideal. And so take the time now. Please, if you want more information about that, I welcome those questions and sharing of those resources. So that's just my little soapbox for today is, have those conversations. A couple more definitions. So hospice care, and I make sure this is separate from palliative care. Hospice care is really for those that are terminally ill, someone who has 6 months or less to live, and hospice services are brought in. It is that interdisciplinary team again, and supporting the family and the patient as they go through that challenging time. Hospice services can include some of those palliative supportive care services, but palliative care is not hospice care. So I just want to make that distinction. And home health care services, as we're going to talk about later, are services that are provided in the home or home-like settings, such as an assisted living, independent living, group home, those kinds of things. That's also included in that home setting in the home health care space. It does include physical, occupational, speech therapy, skilled nursing services such as, doing medications, changing bandages, that kind of thing. It does not include those homemaking services such as cleaning, taking errands, those kinds of things. Those are not traditionally covered under home health care. That's billable. And so that information will not be in here, but those services that are under the home health in this category are included in this information. So we want to pop this poll question up. Have you done any of the advanced care planning? Now that I shared a little bit more, I want to know if anyone has actually done that. So we'll give it a few minutes. feel like we should have some Jeopardy music. All right. Oh, wonderful. I love that we have the majority of people that actually have had these not expected results, but very pleasantly surprised. So good job, and thank you guys for doing that. It's very, very important. So kudos. All right. And now I'm going to turn it over to Megha.
Hello, everyone. Good afternoon. I am Megha Jha. I am a healthcare analyst with Civic. I am the lead analyst on this project. Have been working on this project over a year now. So one of the first step was to understanding what palliative care, what Kari had just described. So that was my learning curve as well. The second step was we collected all our database, which we have since 2012, send it to CDPHE, which is a Department of Public Health and Environment, and we asked them to match that with the death file. Once they have matched it, they send it to us, and then we filter it out based on multiple inclusion and exclusion criteria. So we send somewhere around 13 to 14 million records over the years, which we have in CO APCD. We received somewhere around 300,000, and when we filtered it out based on dissidents or the members who passed away in 2019 and 2020, we found about our cohort size to be 62,000. Then we wanted to look into chronicity and the long-term effects of such large disease, and wanted to see disease progression and its impact on healthcare resources. So what we did is we removed traumatic deaths, accidental, suicidal, homicidal, any of such death which could not be related to disease. We removed them. We also removed people with multiple claims after date of death. So if in CO APCD, if we have a person has more than one claim 30 days after their date of death, we remove them because according to CO APCD, they are still alive. So there could be, that's one of the data errors which we had to remove. Next, we filtered it out based on the eligibility or inadequate claims history. In this step, we did multiple steps. First step was to look if they were 50% eligible in last 3 years before date of death. And lastly, to see hospice care and home health utilization more prominently, we filtered it out for complete or full eligibility in last 6 months before date of death. So once we did that, we got the cohort population, which we had done majority of analysis, is 37,929 members. These are unique members. And once we have this cohort members ID, we pulled their 4 years preceding their death, the data, to see what was happening with them as in a healthcare setting. So the further analysis, which you would see, is on 37,929 population. Moving forward.
Megha, we just have a little comment. Can you speak up just a little bit, please?
In the chat box?
No, just a little louder voice.
Oh, okay.
Thank you.
I'll do that. Moving forward, we are showing various analysis. The first analysis is about the study population, their breakdown by demographic. So we wanted to show by different demographics which we have in our population. First one being age breakouts. In age breakouts, we have divided the population under 45, then 10 years increment until 75 years, and then above 85, we have kept in the separate group. As you can see, the large majority of our population, about 80%, is above 65. So that which is what we wanted to see based on the chronicity of the diseases and the progression. And in the gender section, you can see 51% of the population was female compared to 48 male. Next, we wanted to look into race and ethnicity. Race and ethnicity data is collected following Office of Management and Budget guidelines. It is based on self-identification. Only race and Hispanic indicator is a mandatory option for payers to send us. All other parameters are voluntary. So our data might not be synonymous with what state numbers are, but when we did the analysis, large population were whites, followed by other races or the races with the people with multiple race, and followed by Hispanic. If we look into state census 2020 population, the white population was 61%, which is kind of very synonymous with what we are seeing, but not with 2 or more races, which is 10% compared to what we have 23. Moving forward, what we did is we wanted to look into various measures, which we have. The first ones, which I just spoke about, was majority of them were demographic. Then we broke down into utilization measures, cost measures, and quality measures. These are the measures which we have done. We won't be speaking about all of them, but some of them, so that if we want to talk, if anybody wants to know more about it, they can reach out to us and we can talk in depth about each measure with them. I want to mention a very specific thing here is analysis was done by payer as well. Each payer, since CO APCD has multiple payers like Medicare fee-for-service, Medicare Advantage, Medicaid, as well as commercial payers. But we also have a population called dual population. These are members with more than one, with a multiple enrollment. One could be Medicare fee-for-service or Medicare Advantage along with Medicaid. In future iterations, you would see how each pair was flaring up against these measures. Next, we wanted to talk about a few of the utilization measures. Here are the top three which we found interesting to talk about. One was advanced care planning, which was one of the focus we have for the project. Second, we wanted to see the observational stay, not the inpatient, just for the people, those who have long diseases, they need to stay for observation in hospitals. And the ED utilization, or emergency department visits utilization. As you can see here, for the advanced care planning, we have high numbers of dual population, which I just mentioned, utilizing or having maximum visits or claims for advanced care planning among all the payers. But when we look for observational stay, we have higher number of population in Medicare Advantage. Overall, our population numbers are high for Medicare Advantage, duals, Medicare fee-for-service, and Medicaid, going in that format. ED utilization, as you can see, the percentage within the population, it was consistently across all the pairs. It was about 60% or around 60% or more for each pair. Duals were utilizing more compared to all other pairs. And just to put a caveat, we have these are the in-depth analysis for last 4 years of the cohort population. I wanted to talk about what is advanced care planning codes, which we use. We use 99497, 99498 CPT codes, which were implemented in 2016 by NQF. And the other measures were 1123F and 1124F. Further information on advanced care planning can be reached out in CMS website. Next, we looked into quality measures. Here are the two main important quality measures: 30-day readmission and 7-day readmission. And these were readmission after they had already had an inpatient visit. So as you can see, readmit rate for 1,000 patients or 1,000 inpatient admits, they were high in duals, followed by Medicare and Medicaid. But if you look at the percentage of the population, they show us that Medicare population is kind of very close by to duals, which were 23 to 22. For 7-day readmission, which we want to see if a person who was released come back because of the same reasoning or not. We see Medicare being highest, followed by duals. So we can see these variation between payers to see how the disease or how the healthcare handling of such population took place among the payers. Moving forward, we wanted to show in-depth analysis about the diagnosis groupers by different payers we have. As you can see, we are looking into 6 major diagnosis groupers, one being circulatory, mental health or behavioral health, respiratory diseases, kidney diseases, neoplasms or cancers, and diabetes. We wanted to show diabetes as a separate to see, because chronicity or the multiple modality of different diseases can be synonymous with such population. And hence, since you can see here, circulatory is kind of high among all the payers, highest being between Medicare Advantage and duals. Interestingly, Medicaid has a lower number of Medicaid members, Medicaid members have lower number of circulatory diseases, mental health, which was high in duals, and respiratory diseases were kind of synonymous except Medicaid. Kidney diseases and neoplasms, as you can see, they're varying over the multiple pairs, but these go synonymous with each another. So there are population with all type of diseases or 2 or 3 diseases. As you can see, diabetes, the high number of population is in duals. So this shows that different pairs, how population is getting affected, and how they are reaching out to each pair or utilizing such the healthcare resources. Moving forward, we wanted to ask you a poll question, because now we have talked in depth about different measures and different demographic. We wanted to know, what do you think each pair would be costing, which is the highest costing pair for CO APCD? Okay, we have a question in chat box from Ryan. Does the 30-day readmission rate apply if someone is initially admitted to a hospital only under observational stay, or observational admissions are excluded? That's a really good question, Ryan. Those are excluded. These are 30-day readmission and 7-day readmission. Both are filtered only after they had 1 inpatient visits, and observational stay is not counted as inpatient in the analysis here. Okay. Oh, we got great poll answers. People think Medicare, fee-for-service, and Medicare Advantage. Oh, and equal number of things about commercial and dual. This is really interesting. We wanted to see, because I had learned a lot during this process, and my expectations were something like this. I was more leaning towards Medicare, fee-for-service, and Medicare Advantage. Moving forward. Here is the first cost analysis we are showing across 4 years by each pair. And as you can see, dual population is highest in costing us. It's about 2,357 million. And these are color coded based on the last year. What we have done is we have divided the last 4 years population by each year of before date of death. So the last 12 months, last 12 to 24 months, 36 to 24, and 36 to 48 months, to see how the disease is progressing or how it is costing healthcare. And as you can see in the 4 categories, orange being the last year, which is highest among all the pairs, which was expected, about 38 to 43, 50% of the total cost, and duals is leading in across all the years. Although we have highest population in Medicare Advantage, we see a huge variation in this cost by each pair. Moving forward, another cost analysis which we did was based on different types of claim, like inpatient, outpatient, professional inpatient and outpatient, and others, which we could not put them into one category. Here you can see we have even done for pharmacy data, and this is only where we have included pharmacy analysis. So as you can see, inpatient is highest among this population, which is quite expected. And last year having majority of the cost, which was about 46 to 51% of across all the pairs. As you can see, we have very synonymous numbers with outpatient and professional outpatient. So these are where we tend, if we merge these two, this would becomes equals to, if not more than, inpatient cost. Pharmacy, we wanted to look into different drugs and related cost of healthcare. Moving forward, we wanted to, since this is very important topic for advanced care planning and palliative care, we wanted to look into how palliative care was affected. These are not easily found claims, and these are not reimbursed. So these are not usually billed by providers. So we are using next phase to look into further into HEDIS measure, different hospice codes and provider, and figure out how different pairs are putting their claims in palliative care section. As of yet, what data we have we can see in the last year has highest number of unique members count by each year, as well as unique encounters. But if you can see, these are the two different Z codes which we have used. You can see it is synonymous. Z code encounter per member having a palliative care it's kind of synonymous across 4 years. So if anybody is using palliative care, it's the number of count for that member is somewhere around 3.5 to 3.8. Next, I would let Kari talk about the insights and the next iterations.
Wonderful. And I was just answering Edward's question here. So great question, something that we really would like to look into a little bit more about the readmission pieces. 80% of the population that is in the study is above 65. So potentially there's some offsetting there to answer that question, but we'll add that to the list and do some more digging on those readmission rates. So thank you. So some of the key insights that we identified here, Medicare Advantage is really having a lot of utilization of services. So we really want to drive in and understand what is actually causing that high use, and is it something that is seen in other Medicare Advantage populations, or is there something unique in Colorado? So that is one thing that we really wanted to highlight and make sure that we do some additional analysis. As expected, we understand that the last year preceding death has the highest use of inpatient ED and observation stay. That's something that, isn't too surprising, but it is something that is not necessarily the best for those individuals. If someone is in their last phases of life, we don't really want them to go into a hospital or have multiple visits to the ED. So we really want to understand some of those drivers. Is it certain geographic areas, that kind of thing, but wanted to at least mention that is the case, that we're seeing high utilization there, and something that we could maybe work to improve on if we understand a little bit more. Advanced care planning codes are mostly in the last year of life as well, which again, if you're enrolling in hospice towards the end of your life, that makes sense. Those conversations happen in that phase. But as we touched on a little earlier, advanced care planning is something that should happen way early, and making sure that we're talking about that and the services that could potentially happen as you grow older and as you go into a more chronic disease state as you progress towards your end of life. And we want to make sure that we're not having a lot of high use services that isn't really what someone wants in that last year of life. And so those conversations can really help to bring that care forward and or not have that care provided because it isn't something that is wanted and is an undue service, undue cost that we don't need. So we do want to have some more insights into that, understanding what that is, and really pushing those advanced care planning messages sooner in life. So we wanted to, did I skip? Sorry. Yes, thank you. We'll go to that poll question number 4 and understand what you might want to see next in our next iteration. So. Getting close. Wonderful. Spencer, you want to close it and we can move on? Thank you. Wonderful. So good portion of you want to really understand that last year of life, which is definitely something that we want to understand as well. So great to see that we're kind of heading in the right direction, making sure we include some of those components in our next iteration, which we wanted to chat about a little bit further. So we'll make sure we take those poll insights and make sure that we do a lot of emphasis on that last year of life. A couple other pieces that we're hoping to do is incorporate 2018 and 2021. We really want to have a good solid year before COVID numbers started to trickle in the end of 2019 and then into 2020. So we really want to have that level out. And then as services are getting more normalized in 2021. So we're hoping to incorporate some of those pieces in there. We do want to understand those home health care services. We had that question about long-term home health. That was something new to me as well, which kind of shocked us, but it was good to know that long-term home health service is being provided and is something that's important for our Medicaid population. And we want to understand what's driving those, what services are being done, that kind of thing. As mentioned, the COVID-19, the top of everyone's minds, we really want to understand some of those drivers. Are we seeing normal trajectories, or is COVID really skewing our numbers? But we want to understand how. We do have pharmacy data in the analysis. We just need to delve into it a little bit further. As we know, pharmacy and medication costs are good portion of what people are utilizing with healthcare services. So we need to make sure we pull that information in and understand it. The palliative care piece, we did include the Z codes, which is just an encounter of palliative care. We want to go further and look at, is someone licensed as a specialty palliative care provider, and what services are they providing under that license? We want to understand, maybe looking at other states that have a palliative care benefit and trying to compile that as in this population. What would that look like if these services were provided? So some of those more in-depth pieces to really understand palliative care and how it can be beneficial for this population. And then we want to continue to present this information to folks through these webinars, through independent conversations, get that information. How are we looking at it now? How should we look at it next? So we really want to make sure that this is not a shelf paper report. We want to make sure that it's actionable and it can help really inform and make an impact on this population. We encourage you to reach out if you have other questions. We're happy to do some more questions in the chat. We also are able to be connected on our social media platforms. And as mentioned at the beginning, this recording will be posted on our CIVHC News and Events event resource page. So please be sure to check that out and share it if you know of other folks that would want to take part in learning about this really cool project. So thank you so much, you guys, for being here, and we'll stay on and answer questions as they come available as well.
Yeah, I just wanted to add to what the poll question was. Yes, we do want to look into last year before date of death, and that is very necessary. But we also want to see if certain kind of disease happening in last year, which is leading to the end of life, and how we can better serve this population. We also wanted to look in depth about how COVID-19 was effective. We did a kind of a SNP analysis on 2019 versus 2020 deaths, and we found that about 58 to 60% of our death population was in 2020. So definitely COVID-19 was driving this population as well. Hence, we want a kind of a 2018 as a control year, and then 2021 as a normalized year, to see if these numbers were what we were seeing is across all different years.
And I just wanted to answer Leslie's question really quickly. So agreed that those non-skilled home health services are absolutely critical to ensuring that the population can remain as independent as possible. Those services, if they're not on a claim, we won't necessarily have them in the APCD, but we can try and look at other data sources and kind of see what that impact would be, but it might be a little challenging with the current source of information right now. Not to discount the importance of that, but definitely something that's going to be challenging. If it's not on a claim, not reimbursable, it would not be included in the data that we currently have. So, but good point. So, all right. So we have another question about palliative care services not being reimbursed by insurance. So there are certain pieces of palliative care that can be reimbursed, such as a physician visit, nursing visit, that kind of thing. There aren't a lot of those other supportive, and you probably know this better than I do, Ryan, but you know, some of those services are not readily available as a palliative care service under a claim. And so it may just be visit by physician or visit by nurse. And those are pieces that we're going to be trying to look at in the next iteration to say, okay, this is a palliative care provider. What services are they providing? What we won't know is if it's a physician visit for a palliative care patient or for a non-palliative care patient. But any of those pieces that you can share about those billing practices, we would welcome, since we're not billers, but we do understand that there's some limitations, but we're hoping to get a little more creative with how we identify palliative care in this next iteration. So. And yeah, Medicare, sorry, I saw the other part of that. So yes, those palliative care services are becoming more broadly available under Medicare. A lot of Advantage plans are starting to have that. Additionally, you know, Medicaid office, who is the one that is sponsoring a big chunk of this project, is very interested to see how that population could benefit from palliative care services and whether or not Colorado could get a palliative care benefit under the Medicaid plans. So definitely something that hopefully it's more readily available, then we can do a lot more analysis and have much better patient outcomes too. So thank you for those good questions. I see that we've gone down to 13 folks, so I think we'll sign off for now, and thank you so much everyone for being here. Please reach out if you have additional questions or insights. We want to hear from you. Megha, thank you so much for all the hard work on this, and we can sign off.
Thank you, everyone.